Hello, I'm Dr. Bill Hopkinson from the Department of Orthopedic Surgery and Rehabilitation. The purpose of today's video is to demonstrate the normal lower extremity examination. We'll discuss the inspection of the lower extremity, looking at the bony landmarks, looking at the surface anatomy, palpation of the joints, and verification and examination of joint range of motion. I think it's important to demonstrate that before you do any examination, you should wash your hands properly before the beginning, and to always be concerned about the patient's modesty and appearance. I'd like to introduce Sal, who's our patient standardized model, who's going to help us with the examination. I think it's important when the patient first comes in, you observe their gait and watch their overall ability to walk to get an idea of what's going on. Hello, Sal. How are you today? How are you doing? If you would mind walking back and forth for me. Sal, if you mind sitting up here. And go ahead and take your socks off. Observation of removing the patient's shoes and socks gives you an additional idea about their functional range of motion and their ability to move. With the lower extremity examinations, you want to look at their nails, their skin fold, looking for any ulcerations or discolorations or vascular injuries. You're looking for scars from prior surgery, and you're evaluating overall alignment of the joints. You're looking for any involuntary motions of the lower extremities, such as muscle fasciculations or a tremor, and any soft tissue swelling. You're also going to palpate the pulses, the dorsalis pedis, the posterior tibial pulses, looking additionally again for any redness, bony enlargements, abnormality, or any signs consistent with diabetes or vascular disease. And also, when you first look at the patient and you look at their overall alignment, it's important to see if they have varus or valgus malalignment, such as you would see in knock knees, which would be valgus, or bow legs, which is varus. It's very common for this vascular disease or diabetes to see ulcerations or lacerations over the malleoli. So I think the bony prominences of the ankle and the heel are very important to look at for any of those things. Now, Sal, if I won't mind having you lay back on your back. As I mentioned before, you want to be very, very careful in preserving the patient's dignity, and to make sure the examination is done with great concern about their privacy. For the orthopedic examination and the examination of lower extremities, I usually use a gown or a sheet to make the patient drape off the lower extremity so that I can free up the extremity and examine it without making them uncomfortable in this part of the examination. We'll start looking at the bony prominences, and we'll start looking at the hip joint. The anterior superior iliac spine is a marker on the pelvis. Then you're going to look and feel the greater trochanter, which is on the lateral aspect of the upper femur. Sometimes it helps to have the patient flex and rotate, and you can feel the prominence over the greater trochanter, looking for any swelling or pain. Going down the leg, you're going to look at the overall alignment of the femur. You get down to the knee joint, looking at the medial and lateral femoral condyles, which make up the knee, the patella joint, the extension mechanism, which consists of the patellar ligament or the patellar tendon, and the quadriceps mechanism, which goes into the patella. Also, you can feel the tibial plateaus, both the medial tibial and the lateral tibial plateau. Using your thumb, you can palpate the ridge of the plateaus, and it's much easier to do this in flexion. Also, you can feel the head of the fibula on the lateral aspect of the knee, which is a bony prominence here. Going further down the leg, again, you can look at the medial and the lateral malleoli, palpating that. The medial malleoli is anterior to the lateral malleoli, and then the forefoot and the midfoot. Now we'll go over the range of motion of the joints. Looking at the hip joint, it's important to assess flexion and extension. And the way you check if the patient has full extension is you flex and stabilize the pelvis against the table. So I have, Sal, if you don't mind, flexing up your left knee and bring your knee up to your chest as far as you can. By doing this, the patient brings the femur and the pelvis up. You can palpate on the lower aspect of his lumbar spine, and if that's flat, then you know the pelvis and the hip is completely flexed. I'll flex up the other side and pull up again for as far as they can, and then when the leg goes down, you see that it fully extends, which means the thigh touches the table. If for some reason the patient's thigh doesn't touch the table, that demonstrates loss of extension, or what we call a hip flexion contracture. And then go ahead and then check the further flexion. The patient should be able to further flex up to 110 or 120 degrees, the knee all the way up to the chest. The hip joint has 6 degrees of freedom, so we looked at flexion extension. Then we want to look at internal and external rotation of the hip joint. So with the knee flexed and the hip flexed, you internally rotate and assess how much internal rotation there is, usually about 40 to 45 degrees. And you externally rotate with the knee outside, and a lot of people get confused. You look at where the knee goes, external rotation, not where the foot goes. The foot goes internally and the knee goes externally. So external rotation, again, about 45 degrees to up to 60 degrees. And then checking AB and adduction. You want to see that it's hip joint measurement, not pelvis measurement. So you put your hand on the opposite anterior superior iliac spine, stabilizing the pelvis, and then you bring the leg toward the midline to assess how much adduction or midline it is. It's usually about 20 degrees. And then abduction, 45 degrees usually. And you're going to see that this is free hip joint motion. If you find that the pelvis is moving with it, then that is not true hip joint motion. Now looking at hip pain, and you're going to assess, part of this is to assess whether the patient has pain with these motions. Hip pain is usually associated with pain in the groin, on the lateral aspect of the trochanter, or down the medial thigh. Any pain in any other spot, specifically back pain or buttock pain, is more likely due to back problems. So it's important to note when you're doing the range of motion whether there's pain and where the pain is located. Not just that it's pain in hip joint, but specifically pain in groin or pain over greater trochanter or down leg. So that's very important. Now going over the knee examination, first we're going to observe the knee, look if there's any swelling, as we saw before, or effusion. Checking for an effusion would be pressing the superior aspect of the joint and seeing if there's any bulging of fluid. We're not going to go over the blotment examination at this time, but if you can see the patella in great profile, there probably is not much of an effusion. Sometimes when patients have a big swelling in their knee, effusion in their knee, you won't be able to see the patella. It'll just look like one giant swollen joint. And I think it's much easier if the patient demonstrates their active range of motion before you start forcing motion, because anytime you force the examination, the patient becomes less comfortable. So Sal, would you mind lifting your leg up and bending it fully? And the observation of this is the active range of motion. This is what the patient demonstrates. Passive range of motion would be with the patient relaxed and then the physician or the examiner changing the range of motion. If there's a difference between active and passive range of motion, it should be noted. The knee should go from full extension, which is 0 to actually 10 degrees of hyperextension, to full flexion, which usually is the heel against the thigh, usually up to 150 degrees. Now looking at the ankle motion, I think it's much more easy to examine the ankle with the knee flexed. By flexing the knee, you relax the gastrocnemius muscle, which goes across the ankle joint. So for examining the ankle joint, the knee is flexed, and you're going to look at, again, having the patient dorsiflex their foot, and that should be about 15 to 20 degrees, and plantar flex the foot, or palmar toward the floor, and that should be up to 45 degrees. Again, I'm looking at the medial and lateral malleoli, observing any swelling or tenderness. Examining the subtalar joint, basically by putting your hand in the upper part of the leg and cupping the calcaneus, or the heel, in your hands, and then looking at inversion, which would be toward the midline, and eversion, and assessing how much motion there is there. The subtalar joint motion is mainly in inversion and eversion, and you want to measure about 10 degrees of eversion to about 20 to 25 degrees of inversion. The transverse tarsal joint is the midfoot, and again, looking at the midfoot, you're going to look at eversion and inversion across the midline by stabilizing the ankle joint and the subtalar joint with your upper hand and assessing that. Examination of the Achilles tendon is very difficult to do with the patient in the supine position. So I'm going to ask Sal if you don't mind going up and standing up and kneeling on the chair. If you're going to examine the Achilles tendon, you want to see it's the gastrocnemius soleus complex, which goes into the tendon. You're going to palpate the width and the integrity of the Achilles tendon into its insertion on the calcaneus. To examine continuity of the tendon, we do what we call the Thompson's test, which is by squeezing the gastrocnemius. If the tendon is continuous and intact, the foot will plantar flex spontaneously, and I'll do that now. So by squeezing his gastroc soleus complex, not very vigorously, doesn't have to be hard, you're looking to see if the foot plantar flexes. If it doesn't, you'd be highly suspicious that there might be a tear there. It should be noted that it's easy to examine the subtalar joint in this position. Again, my hand on the upper part of the ankle, my foot on the calcaneus, the knee is flexed, and I can measure inversion and eversion quite easily. Go ahead, Sally, you mind standing up there for me? I think it's important to note that for the purpose of the examination, I didn't show examining the right and left side, but the right and left side should be looked at the same time. You should practice, practice, practice. That's the best way to get your physical exam down. And remember, you should always wash before and after you examine each patient for protection. I hope this helped. Thanks a lot.